Welcome. I'm Dr. Ken Piper, and this is a video series of learning and teaching that I've created titled The Wonder of Our Bodies. This particular session will focus on the body's nervous system and the components of it. There'll be three parts to it, kind of dividing up the nervous system in some, I hope, logical ways for you. The intention of this series is personal learning, stimulation, excitement. There's miracles inside everywhere in every second of our existence. And my hope with this overall series is that you get a little bit of a kind of drop your jaw, this is awesome kind of feeling that might stimulate you to learn more. I also hope it'll give you some information, terms, knowledge, insights that can help you work with your healthcare providers in a more partnership kind of way. And we're going to try to make it fun all the way through. So thank you for visiting my website. I hope you enjoyed part one. And we're going to talk about brains, spinal cord and nerves. I put the brain in plural because we're going to look at the head brain and also the gut brain. Two separate brains, they talk to each other. Pretty exciting what we're learning about the gut brain, just very, very interesting dynamics of what it's measuring, how it's responding, decisions it's making, and how it communicates. Spinal cord, of course, important big telephone cable between the brain and the bottom of the spine, sending all those messages up and down. And then we're going to talk about nerves, and again I use the plural because we have peripheral nerves that go out into our arms and legs, again sending messages down, bringing messages up. But we also have nerves around the face and head. They're called cranial nerves, and they come from the ears and eyes, from taste buds. They work with facial muscles. Everything from the neck up is measured and controlled and responded through the cranial nerve system. So just a quick picture. This is an MRI right through the middle of a head. And you can see the inner structures down on the bottom. That white cord coming up is the spinal cord. It moves up into several sections of what we call the midbrain. And I'm going to talk about those a bit later. Flows up into a distribution system that then sends all kinds of messages way up to the top. And that wavy stuff you see up there is the gray matter of our thinking brain. But let's start with peripheral nerves to make that clear. And we're talking about nerves that either carry messages up to the brain or nerves that carry messages down to the brain. So you can see that nerve on top with the blue cell body. That cell body is near your spinal cord. And that nerve goes from your spinal cord all the way down to your foot. So let's just focus on that particular nerve. This is a sensory nerve, which means on one end it has little sensory endings that are picking up messages. It sends those messages all the way up to the nerve body and then out further from the nerve body right up into the spine. So downstream on a sensory nerve are little receptors for touch, vibration, heat, cold, movement, pressure, tension, all different kinds of sensations measured by little receptors, different receptors for every kind of sensation. The movement then, the sensor sends a little message, and it's not really electricity like you have in your house, but it is a change in electrical potential along the cell of that big axon. And so when you think about it, the little bitty sensor has to send a message 4 feet all the way up to your spinal canal. That long nerve is called an axon, and it has cells around it that act like insulation. These little cells called glial cells wrap themselves around the nerve to protect it. The red cell you see is called a motor neuron, and it fires off a message down its axon. You can see there the little red fingers at the end. Every one of those red fingers hooks into a muscle fiber. So when the red nerve fires the motor message, the muscles get a little chemical stimulation and they contract. Inside the spinal cord, you can see that yellow nerve. It's connecting the sensory nerves and the motor nerves. And the sensory message goes all the way up to the brain. The motor message comes all the way down from the brain. But inside the spinal cord, you can see that the sensory and motor kind of link real quickly, which is valuable because if your toe steps on a tack and the pain goes up that blue nerve, it'll rapidly fire, drop down to the red nerve, and the red nerve, a motor nerve, will say, "Oh my gosh," and it will pull your leg away. So we will get away from pain quickly without the brain even involved. And this is called a reflex arc. It's a nice little system we have to protect ourselves. And you all know this is true. You can get close to a burning candle, but at some point your body will pull you away even though your brain says don't. Some of these nerves are longer than others. Some are shorter. Some are thicker. That changes their ability to carry messages. The nerves are protected. As I told you, they all individually have a wrapped protection. You can see that down on the bottom. But the nerves bundle up together, and then the bundles bundle up together. So if we actually look at a nerve in a human body, it may contain 10,000 small, tiny nerve fibers. This is a simple diagram of a cluster of nerves coming out of the neck. Those nerve roots, you can see that. And then very simply, the nerve roots divide, in this case, into a nerve that goes underneath the wrist into the thumb, first and second finger. That's called a median nerve. Another one goes down on the outside of the elbow to the fifth and fourth finger. That's called an ulnar nerve. Now that's a very simple looking diagram, and you think, well, that makes sense. But when you start looking at more detail, here on the left is the median nerve, and the middle is the ulnar, and on the right hand side is actually another one called the radial nerve. But you can see the detail now of all the different branches and how they flow back and forth. And those nerves have to flow around joints, through muscle bundles, underneath ligaments. The same thing in the leg. You go down in the leg and you'll see, this is on the right hand side is a view from the back, and you can see out of the back of the spine that huge big dark band coming down is the sciatic nerve. And it rapidly branches into three main branches that go down to your toes. So the sciatic itself is down in the butt muscles and comes down a little bit toward the middle of your thigh. And it's a big bundle of many nerves wrapped together. On the left-hand side of that picture are the spinal nerves that come to the front of the leg. Now, these nerves in your leg are 4 feet long. In the arm, they're 2.5 feet long, which means they're vulnerable. They're vulnerable to be squeezed, to be compressed. They're vulnerable to be cut. They're vulnerable to be infected, inflamed. They're vulnerable to toxic things that may happen in the body. And when these nerves get damaged, we use the term peripheral neuropathy. Peripheral means outer nerves, and neuropathy means bad things happening. So here's another nerve diagram. The green is the cell body. There's that long axon going all the way down to the end terminals, and the red are these cells that are wrapped around, providing an insulation. Remember again, just for visualization, that one little nerve is wrapped and wrapped and wrapped, so 10,000 are all together. One of the most common causes of peripheral neuropathy is diabetes. On the left, you see tiny, tiny little blood vessels that are nourishing a nerve. On the right, you can see diabetic changes in the walls of the artery are affecting this microcirculation. This nerve is not getting nutrient flow, not getting enough oxygen, and you can see it's becoming more sickly. The outer insulating sheath begins to break down. The nerve axons begin to break down. And this will produce a damaged nerve that will be sending false messages up to the brain. The simplest test we do in the office to see if there's a peripheral neuropathy down in the legs is this simple pressure test. That pin you see has a piece of fish line. When we push the fish line against your skin, we can deliver measured amounts of pressure. So, for instance, this could be 10 grams of pressure. So I take your shoes off and your socks off, I tell you to close your eyes, and I basically, very simply just say, every time you feel a touch, say yes. And I'll touch 7 or 8 places on the foot, and if you respond yes, 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 then I know your nerves are working fine. If you don't respond appropriately, then I know there is an ongoing neuropathy. Something's going on in your nerve flow. You may not have any symptoms, but unfortunately, many folks with neuropathy feel things. And as I mentioned, this is false messages. So false messages means your brain might be perceiving pins and needles in your feet. They're not really pins and needles, but the message is false, and the brain listens to the message. Patients with neuropathy can feel burning, fiery. They can feel cold. They can feel their feet red warm. They can feel funny sensations like their socks are kind of bunched up. Tingling, various kinds of numbness. And this can shift around the foot. It could be better and worse on different days. Tends to be worse at night when your brain's trying to calm down and begin its recovery phase. So neuropathy is a lot of symptoms. The long nerves in the legs are vulnerable first, then the long nerves of the arm. So most neuropathy starts in the toes and feet, works its way up toward the knee, then it shifts up into the hands and fingers, works its way up toward the elbows. In patients with diabetes, because they don't feel normal things on their feet, they don't know if they get a blister. Here's a patient who is rubbing his shoes on the big joint of his left foot, and rather than just a callus or a little sore spot that you and I might get, this patient actually just dug a hole in his skin and has an ulcer. Doesn't feel anything. We teach patients with diabetes to examine their own feet frequently. In some cases, every 2 or 3 weeks. Look at the finger, look at the toenails, look between the toes. Look for rubbing areas, redness, infections. Look for sore spots. Feel all the bones. See if there's any skin reaction going on. Because one of the tragedies of diabetes are neuropathy-related ulcerations, which then can lead to infections, and the circulation's impaired, which can lead to more infection, which can lead to gangrene changes, which can lead to various types of amputations. When I find a peripheral neuropathy, I have to think through about 20 causes. There are inherited patterns, metabolic, chemical problems in the body, toxicities, various kinds of inflammation, a bunch of deficiencies that can hurt the nerves. And I mentioned pressure. You have a lot of points in the body where the nerve can get rubbed and trapped against something or under something. The nerve gets inflamed, and then you get a neuropathic symptoms. The most common is in the lower back, where the big spinal nerves coming out of the spine get trapped. And we'll talk about that in part 2. We call this spinal stenosis. And we'll go over that in some detail because it's so common. I want you to really understand it. Chemotherapy can cause nerve damage, neuropathy, and sometimes permanent. Now, when I deal with neuropathy, the common things I'm going to think about, metabolically, diabetes and alcoholism, Toxic things, metals like lead and mercury that can accumulate in your body. There are some drugs that are toxic to nerves, and in particular, increased concern now about a class of antibiotics called fluoroquinolones. I'll mention just one name that you may have heard of, a drug called Cipro. Valuable antibiotics when indicated for the right reason, but the potential is there to cause an acute and sometimes severe neuropathy. So we don't like to use that class of drugs unless it's absolutely indicated, and we will tell you that there's some risk with it. Shingles is an infection of a nerve. There's a lot of autoimmune conditions that attack nerves, in particular multiple sclerosis. The most common deficiency is a B12 problem, and that can occur even with good nutrition. Rubbing and pressure we call entrapment neuropathies. I'm going to show you a couple examples. And spinal stenosis is the most likely thing when people talk about leg pain. Let's look at a couple of examples that I've picked out for you. Firstly, a condition called herpes zoster, which we all know as shingles. So the chickenpox virus hides in our body. Chickenpox at age 5, you think you're over it, but the viral particles go and hide inside the spinal cord, inside cells that the immune system can't find. They hide out. The immune system doesn't know they're there. Until 40 or 50 years later, when they activate and begin to multiply, and they travel down a nerve, a peripheral nerve, to get to the skin. Now, they could pop out on cranial nerves up around the eyes or face. That's pretty awful. But usually it's the peripheral nerves in the upper arms, around the trunk, sometimes the legs. Here's an example, a pretty dramatic example. Here's a man who had hidden herpes virus at 4 levels in his spine. They all activated at the same time, and you can see the kind of streaky pattern of this infection. It travels down the nerve and causes great pain and numbness and different sensations, and then the virus pops out on the skin. This is an easy diagnosis. It's a tough problem when the nerve gets sort of hung up, when the virus gets hung up in the nerve. If the virus just irritates and inflames the nerve but never comes to the skin, we get a situation where we can't make an easy diagnosis. Here's an example of a common problem you've probably heard about called carpal tunnel. This is an entrapment neuropathy. These patients come in and complain of numbness, burning, and tingling in the thumb and the first 2 fingers. And the problem is, you can see that yellow nerve is being rubbed right underneath the wrist. And the reason for that is that in the wrist there's a band of tissue that holds the bones together, and the median nerve has to run underneath it, like in a tunnel. The other nerve to the hand, to the 4th and 5th finger, is on the outside of that tunnel. So carpal tunnel, we have ways to reduce the pressure, kind of open it up. Sometimes we have to surgically open it up and cut it and release the tension. There's a similar problem down in the feet, which is called tarsal tunnel. Similar to the wrist, there's a big nerve called the posterior tibial that runs on the inside of your ankle. You can see that yellow nerve. It's underneath a big ligament. It's in a small tunnel. It can get trapped and rubbed, and now you get pain and numbness and tingling going down the inside of your foot to the toe. There's, I think, 15 or 20 places in the body where these nerves come to the surface enough that they can be rubbed, irritated, inflamed, and cause trouble. So we're always thinking about that when we're dealing with someone complaining of pain or numbness, especially if it's only one leg, one arm, one place in their body. Most of the inner peripheral neuropathies, from metabolic or toxic or inflammatory or autoimmune causes, most of those will hit both sides of the body at the same time. And the last example for you is Bell's palsy. This is an inflammatory condition of one of the nerves in the head. This is an inflammatory reaction occurring in the base of the 7th nerve, which controls the muscles of the face. Bell's palsy, this inflammatory reaction, can be kicked off by viral infections, other situations. And here's a young boy with Bell's palsy. We asked him to smile. And you can see that the right side of his face is paralyzed because the facial nerve isn't working. The left side of his face is fine. He smiles. You can see him pulling up his lips. You can see the smile glint in his eye. But the right side is in trouble. That lid doesn't want to close. Most Bell's palsy will respond. The nerve will heal. Remember, nerves are delicate. They've got this outer protective insulation, and a damaged nerve is really slow to heal. Some patients with Bell's palsy will not totally respond. So I thank you for your attention. This is part 1. I invite you to listen to part 2, and we'll pick up this same theme and go into the spinal cord. Thank you again.